I'd like to thank the organisers very much for the invitation to speak today and to hope that you're all keeping well at home in these difficult times. So I'm going to talk about the neuropsychological evaluation of early dementia and mild cognitive impairment. Here are my disclosures, the most important of which is that I'm a neurologist and not a neuropsychologist, and so I'm going to give you an overview of this topic from my perspective as a clinician seeing patients and not as somebody with particular expertise in neuropsychology. So to get started, it's worthwhile reviewing what we think is occurring during the progression of Alzheimer's disease. Clearly, Alzheimer's disease is not the only form of dementia, but is the dominant form and the one that is leading our discussions and our thoughts on the evolution of neurodegenerative diseases. The definition of dementia is that individuals start cognitively normal and will go through a transition phase, which is often termed mild cognitive impairment before they develop dementia, in this case Alzheimer's disease. And in the case of Alzheimer's disease, we think there's a sequential changes that occur, first with the accumulation of amyloid within the brain, then with the accumulation of other brain proteins, including tau and hypometabolism within the brain, then structural changes, typically in the form of hippocampal atrophy, then progression with cognitive impairment, which then impacts on activities of daily living. So if we turn now to the main topic of today's talk, which is on the neuropsychology, and we look at what this graph tells us, it tells us that people, as we've discussed, are starting from a cognitively normal baseline. They are then progressing through a period of mild cognitive impairment before reaching Alzheimer's dementia, by which time there's impairments of daily living. Importantly, there is an upswing around here, so when the cognitively normal phase is still there, when there are some subtle changes, there's a progressive change in mild cognitive impairment before dementia is reached. And clearly you can see that these lines here are inevitably purely arbitrary at which stage we determine somebody has gone from cognitively normal to mild cognitively impaired and from mild cognitive impairment to Alzheimer's disease. In order to try and operationalize this, the new National Institute for Aging clinical guidelines have been developed. And these look at several different stages from normal cognitive impairment through to preclinical Alzheimer's disease, by which time there is no symptoms reported by individuals. And then when we enter the symptomatic phase, mild cognitive impairment and then Alzheimer's disease. And it's at this stage that we can use clinical criteria to diagnose people with Alzheimer's disease, whereas before that, it's for research purposes only. And the NIA criteria acknowledge that there are clinical aspects to this, but also that it's important to use biomarkers to try and determine the underlying pathologies, something that we'll come to later. So if we take a step back and think about the various terminologies that we use, the terminologies have clearly changed over time and have developed over time. So initially, there is the acknowledgement that there are some cognitive changes that are part of the normal aging process, that people's memory, for instance, is just not as good on average in their 70s or 80s as it might be in their 20s or 30s, even if there is no apparent dementia or neurodegenerative process coming on. And these have variously been defined as benign senescent forgetfulness, as age-associated memory impairment, or as age-associated cognitive decline. And all these criteria are coterminous and suggested to be all part of the normal aging process. We then had emergence fairly recently of people who have subjective cognitive impairment and groups with subjective cognitive impairment plus. And these individuals have no objective problems with their memory, so sensibly would fall within the normal aging category. The difference being that they do have subjective complaints that their cognition is not normal. And then we reach the stage when people do have objective problems, and these have gone through various iterations in terms of nomenclature. with cognitive impairment, no dementia from the late 1990s, and really has taken root in the early 2000s work with Ron Peterson and others who define this entity of mild cognitive impairment and then mild neurocognitive disorder as determined by DSM-5. So we've got no complaints, we've got some complaints, and we've got either the absence or presence of objective problems. Added to this is a really sort of recent player in this scheme, which is patients with functional cognitive disorders, which we'll come to later, but can span several of these different domains. So, of course, why is the interest in this? Why to try and define these different groups? Well, there is an interest from a certainly research perspective and looking towards public health in people who have apparently normal aging to see whether we can identify people with preclinical disease who are going to go on to develop cognitive impairment and dementia, as this may be the ideal time to intervene and try and prevent cognitive decline. For patients with mild cognitive impairment, the main interest here is that these individuals may be on a trajectory to getting frank dementia. So as a prelude, and supporting this is that patients with mild cognitive impairment have higher rates of conversion to dementia, around 10 to 15% a year. But the issue here is that not all individuals with mild cognitive impairment will develop dementia. Some will remain static, some may even recede. And how can we determine who is at risk? And that's important because if we do have new disease-modifying drugs, we may need to treat at this very early stage. Patients with mild dementia, it's clearly important to diagnose, both for treatments that are licensed now, but to provide appropriate intervention support to help them and their caregivers, and also access to clinical trials. The subjective cognitive decline group may be an at-risk group for developing mild cognitive impairment and dementia in due course. And some of these individuals, however, may not be on that pathway and may require specific treatments, for example, for depression or reassurance. And likewise, patients with functional cognitive disturbance may require specific interventions. But for all groups here, whilst there's an increasing move to using biomarkers to try and define at-risk groups, the cognitive evaluation is the starting point and the principal key. If we look then at the key criteria, trying to break this down into a simpler scheme as possible, we have normal aging when we have no symptoms, objective impairment, or impaired activities of daily living. Preclinical dementia, no symptoms, no objective impairments, and no impaired activities of daily living. Mild cognitive impairments where we have symptoms and objective impairment, but no activities of daily living are impaired. And mild dementia, we have all three present. The subjective cognitive decline have symptoms, but no objective impairment, and no impaired activities of daily living. And the functional group have symptoms, may or may not have objective impairments, may or may not have impaired activities of daily living. But what's important here is that at the key and the heart of this, the symptoms and the impaired activities of daily living can be gained by history, but is to determine the presence or absence of objective impairment, ideally using standardized tests. So this is when the neuropsychological evaluation comes in. And some key questions that need to be addressed is how to assess cognition. Which domains of cognition should we be assessing? Is it okay just to use some screening test, or do we need to use formal neuropsychological evaluation and assessment throughout? What are the key criteria for a useful test, and what are the pitfalls of using different tests? And how do we define what's clearly rather arbitrary, which is when somebody becomes impaired on a test? And then I'd like to cover what tests and approaches we might use to distinguish mild cognitive impairment from normal aging, subjective cognitive decline from mild cognitive impairment, and to diagnose functional cognitive decline, and also touch on where research is heading to detect preclinical disease, and finally to see where we are headed. So if we turn to which domains to test, well, the initial group of individuals who were defined as having mild cognitive impairment were defined as having amnestic mild cognitive impairment. So they'd have cognitive complaints which are not normal for age, they're not demented, they've got cognitive decline from a previous baseline, they've got essential functional activities are normal, and they have amnestic mild cognitive impairment. Their memory is impaired, and this is the rationale for this, is that most of these individuals will be going on to get Alzheimer's disease. But things have become more complex. We now think about patients with amnestic mild cognitive impairment, and I then ask whether this memory impaired is only the only problem, and if so, it's a single domain mild cognitive impairment, and if not, multiple domain. But of course, not all patients who are transitioning from normal aging to dementia will necessarily be going on to get Alzheimer's disease, even those who will get a degenerative dementia. So what about the other dementias? What about frontotemporal dementia, dementia with Lewy bodies, other conditions as well? So now we have the added complexity of non-amnestic mild cognitive impairment, which again can be single or multiple domain. And each of these different criteria have a different potential prognosis, although with very considerable overlap. So when we think about which domains to test, the focus still remains quite rightly on episodic memory, as Alzheimer's disease is the single biggest cause of dementia, and this is affected very early in so-called typical amnestic Alzheimer's disease and is a core criteria for amnestic MCI. But with, as we've discussed, the evidence for multi-domain mild cognitive impairment, which may be prodromes of other dementias, we also may need to think about other domains, so to assess general cognitive function in terms of both a verbal and performance IQ scores, to think of other aspects of memory, semantic, topographical, to name but two, to think about naming and language, parietal lobe function, both dominant and non-dominant, and executive function as well. So which test should we use? So those of us seeing patients in the clinic as neurologists, as geriatricians, as psychiatrists, are likely to do some screening tests to start with. And there's a large array of different screening tests that we have to call on. The abbreviated mental test score out of 10 is a very brief screening test score, often used in general medical wards and primary care settings, but it's very, very brief and very, very crude. The mini-mental state examination, very widely used, is scored out of 30, and commonly a cut-off of 24 out of 30 may be used, although many other cut points are also determined as well. So this is widely used and does provide some objective scoring and can be a useful staging and is quite quick to do. One of the issues here is that it's heavily biased on verbal scales, again being specifically used to diagnose Alzheimer's disease, is not very sensitive to mild impairments such as the ones we're interested in here, and is not terribly useful for differential diagnosis, and in particular patients with even quite advanced frontotemporal dementia may score very well on this test. The Montreal Cognitive Assessment, the MOCA, is similarly scored out of 30, and with a cut-off for scores of 26 out of 30, and again is a little more comprehensive than the mini-mental and less perhaps biased towards just the naming and memory domains, but again is not suitable for more advanced stages of dementia and has limitations in determining very mild changes. The ACE score, scored out of 100, does incorporate many different domains. There's various versions, the ACE-3 being the most recent, with cut-off scores of 82 out of 88 out of 100. So this has been quite well validated in neurodegenerative diseases and is useful for tracking change over time, and is relatively sensitive to subtle cognitive impairment, but can take a little time to use in clinical environments. And this is a summary from Sajadi and Nestor in the Oxford Textbook of Cognitive Neurology and Dementia. So screening tests, do have advantages, particularly as one moves down this scale. But what about formal sort of neuropsychology? What can that offer? Well, neuropsychology offers a quantitative assessment of cognition, both strengths and weaknesses. It allows comparisons with age-related normative scores and can, to some extent, be compared with pre-morbid estimates of performance. It's a very useful means of tracking change over time when the same tests can be done serially, allowing for changes on percentile scores to be directly compared. And it allows assessments of multiple different cognitive domains, including memory, language, attention, speed, visuospatial, executive, and others. And using this to provide an indirect assessment about brain function and pathology. And I say indirect is that there are some good correlations between how the neuropsychology tests perform in various different domains and the domains affected, but there is overlap, and so these are used almost always in conjunction with biomarkers of brain structure, function, and ideally molecular pathology. So as memory is really the most widely tested domain because of its relationship with early Alzheimer's disease, it's worthwhile just thinking about what we do when we're testing memory. We'll often give a stimulus, which then needs to be registered, so in other words, put into the memory store, then consolidated and stored, and then retrieved after a suitable interval and reproduced. And so where registration goes wrong is often, particularly in the mild stages, when there are attentional resources like are impaired, for example, in depression. Consolidation and storage is a hippocampal problem, and then retrieval is often activation of strategies such as frontal dysfunction to be able to pull that information through, provided it has been appropriately registered and stored. So this is a sequential pattern. So when we're thinking about what tests to use, we need to consider about task difficulty. So for detecting early disease, individuals will often do very well on fairly standard, simple memory tests. And so it may be important to use demanding cued and uncued tests, such as the free and cued selective reminding test. For mild to moderate Alzheimer's disease, then forced choice tests are often helpful. So these are the recognition memory tests when individuals are given stimuli to remember, and then after interval are given a choice with that and a number of distractions to choose. And for advanced dementia, you need simpler instruction demands, such as the severe impairment battery. So when we're interested in detecting early disease, something like the ceiling and floor effects. So here we have tests done serially over time. We've got 3 patients here. In the first patient 1, the test is really too simple, and so they can score at ceiling levels despite having declined over time. Patient labelled in the triangle again has declined over time, but the test is too difficult, so they've scored very badly at the start, which means there's little dynamic range for them to fall any further. Whereas the patient in the square with the dotted line in the middle has shown decline over time, and has used an appropriate test with a sufficient dynamic range that they've been able to score not at ceiling at the start, but there's still room for them to decline without falling outside the normal range of the test. So the dynamics of the tests are very important, particularly in mild or severe disease. Again, as well as thinking about the sort of dynamic range of the tests in terms of ceiling and floor, we need to think about how gradated the tests are to see whether they can determine changes over time or differences between individuals and allow for multiple levels of severity. So we've spoken before about graded tests in terms of their difficulty, and one way of looking for particular subtle changes to incorporate tests that have a timed element, so that even if individuals get the correct answer, if they take longer to get to that correct answer, that may be a sign of very, very subtle change from their baseline. And again, if we use tests that are normally distributed, they can be standardized for comparison. So here we see a very standard bell-shaped curve with its percentile scores, and show how that these can be converted to t-scores and then standardized scores, allowing for direct comparison between performance of tests of different degrees of severity, again allowing patterns of impairment to be compared. In terms of other factors to consider, we need to consider confounding and collateral deficits. So few tests are very pure. At a trivial level, if the Freed and cued selective reminding test relies on vision, if people have got poor vision, or indeed poor semantics, they may perform badly. So one needs to take into account those changes as well. There's an increasing use to use composite scores. So, of course, some of the screening tests that we mentioned previously, the mini-mental state examination, the ADAS-COG, are composite tests. And composite tests of neuropsychological scores are increasingly being used in clinical trials of very early Alzheimer's disease, perhaps rather less in practice. So, for example, the preclinical Alzheimer's cognitive composite, which has been designed and shown to be quite sensitive to change in preclinical, very early Alzheimer's disease, contains many different domains, including the word list recall, logical memory recall, digit symbol substitution, and the mini-mental state examination. And particularly if one is doing tests over time to assess either whether there has been objective evidence of decline or to the extent of that, or for outcome measures for clinical trials, practice effects are particularly important. And so using tests for which individuals can't have a hangover from their previous performance or can't practice in the meantime is also important. So if we thought a little bit about the different dynamics and the different properties of the tests, if we turn now to what actually happens in practice. So how is objective impairment defined? And the answer is really very variably. And we've spoken about the criteria for amnestic MCI being declined from premorbid functioning and normal activities of daily living. But how is objective memory impairment declined, and the impairment for age? Now, sometimes this is done on history, and sometimes, but not always, it's operationalized in some way. So, for example, people might have a score of 1.5 standard deviations below an age-related norm. Of course, that's going to be more complex and more difficult for some individuals than others, and implies that a certain number of the percentage of the normal population will have fail on a test of memory. So therefore, one is dependent on defining that this has been a decline from normality. And in practice, different centres use this very, very differently. So defining abnormality in a more general sense is not at all straightforward. And we've heard that this can be operationalized using, say, the cutoff scores that we've mentioned on screening tests, such as the MMSE, the ACE-R, the ACE-3, as previously demonstrated, or we can use this arbitrary 1.5 standard deviations from the mean. But there are many other factors as well that will depend on effort, on premorbid functioning, how good people are before their cognitive symptoms emerged, how good the normative data are, and other factors. And again, if we go back to this bell-shaped curve here, we can see that if we take 1.5 standard deviations below the mean as a cutoff, there are going to be a large population who are already at this level. And similarly, if you are starting at an average range, you have to decline less before reaching this cutoff than you do if you're superior or very superior memory scores to start with. So you'll have further to fall. Moreover, there are a lot of other factors that will influence your cognitive performance, which are usually not taken into account. So this is work from Kirsty Liu that we've done on the 1946 birth cohort. showing that these scores, which make up the preclinical Alzheimer's composite and the preclinical Alzheimer's composite itself, are all influenced by sex, so women generally perform better, and they're all independently associated with childhood cognition, with education, and in many cases with social class, showing that there are influences across the life course and some biological influences on people's cognition. So there are lots of problems in defining a cut point for which somebody becomes normal or abnormal. And again, if we turn to what happens really in clinical practice, so this is a very large study of which is aimed at looking at biomarkers and to see how they can be used to predict progression from mild cognitive impairment to Alzheimer's disease. And this is work published in Lancet Neurology this year. And what you can see here is that we've got 4 very large cohorts, and so these are from very large research studies from the States and from Europe, and whose data were used for this study. So if we just look for the inclusion criteria, so these are how the mild cognitive impairment group were defined, and you can see in one study they were referred to memory clinic but just don't fill criteria for dementia. Another has memory complaints verified by a study partner and abnormal memory functioning, a mini-mental of 24 to 30 to exclude mild impairment, clinical dementia rating of 0.5, so that's of mild symptoms and doesn't fulfill criteria for dementia, so fairly strict. In this large multi-centre European study, this varied very much by subgroup, and in this Biofinder study, there were patients referred to memory clinic with baseline mini-mental of 24 to 30 who don't fulfill criteria for dementia. So you can see in practice, even in these very large centres, there's quite a wide range in how people are defined as having mild cognitive impairment. It's interesting also just to demonstrate that mild cognitive impairment is not necessarily always a prequel to dementia. And if we look at the conversion over 5 years to dementia, you can see this varies between 31 and 55%, which means that at least on average half people diagnosed with mild cognitive impairment do not develop dementia, at least over that time frame. So if people have cognitive symptoms, but don't have objective impairment, there's been a criteria of subjective cognitive decline has been proposed. And again, key factors here are clinically reported symptoms, but no objective cognitive impairment. And here in these consensus statement about mild cognitive impairment published in the Lancet Neurology this year, it said that this is difficult to judge clinically and likely to be highly variable between clinicians, which I think marries up with what we saw before about the diagnosis of criteria for MCI. It said that the screening tests, such as the MMSE and MOCA, are likely to have limited diagnostic accuracy. And this is when we're trying to determine very, very subtle changes. And so what's recommended is comprehensive neuropsychological test batteries, which look at different domains and which take into account some of those factors that we've discussed before: age adjustment, sex adjustment, and education adjustment normative data. And again, it's made clear that there's no universally accepted cutoffs here. 1.5 standard deviations below the mean on a specific cognitive domain, or below 1 standard deviation but on 2 separate cognitive tests, or below 1 on 3. It's really not clear at all what criteria should be used. And what about functional cognitive disorders? So a lot of us see patients in our clinics with lots of cognitive complaints who may or may not have objective cognitive impairment, who we feel their complaints are related to functional problems with memory rather than objective problems. And one of the keys to this group is people who are internally consistent. So they can do a task very well at some times, but very poorly at other times, particularly when attention takes place. But that's not the same as fluctuation over time that we might see in delirium or dementia with Lewy bodies. And in these individuals, the cognitive tests are often very helpful. These individuals have cognitive complaints and to do very badly, but there's fluctuation, there's inconsistency in how they have conversation during an interview, how they perform compared to their activities of daily living, and, for example, sustaining a cognitive demanding occupation yet doing very badly on testing, or when they test very badly in certain situations, for example, with neuropsychology. And the neuropsychology can often be helpful here, showing incongruent patterns. So, for example, people who have real difficulty registering information, but much better at recall. So this is when objective evidence of cognitive impairment, of cognitive performance, can be extremely helpful. And this can be very difficult to distinguish at times between patients with subjective cognitive impairment and mild cognitive impairment, and indeed can overlap with all of them. And what about preclinical change? Well, we said that actually where we're ultimately going, would like to go to, is to be able to detect people who are cognitively normal but already showing some subtle changes. And I think this is exemplified here in a case that we wrote up several years ago. This is an individual referred to our clinic, and he was extremely high functioning, but his complaint was that he used to be able to think several moves ahead in chess, but this had reduced down. And here we saw him, and he performed well in all screening tests. And then a year later, he remained stable. Then a year after that, he developed mild cognitive impairment, and a year after that met criteria for mild Alzheimer's disease. And what we're showing here is a coronal section through his brain imaging, and we can see here in this lower panel that there is clear hippocampal atrophy, which will be in keeping with Alzheimer's disease. This gentleman died with a diagnosis of very mild Alzheimer's disease of other causes, and at that time he had brain histology which showed Braak stage 6 Alzheimer's disease, so advanced Alzheimer's disease with plaques and tangles and cerebral amyloid angiopathy. So it seems very likely that this man, who had very objective complaints of his cognitive performance despite performing within normal limits on conventional tests, who showed pre-symptomatic excess hippocampal atrophy and died at a mild Alzheimer's stage with advanced pathology, is demonstrating what we know, which is that normal aging contains patients with pre-symptomatic diseases. We're really seeing the tip of the iceberg by the time people are presenting. And again, this is work from Kirsty Liu from the study of the 1946 birth cohort, when we're taking individuals in their early 70s and doing amyloid PET scans and then looking at their cognition. And we can see that those who have amyloid PET abnormalities are already performing as a group worse on several tests here than those without amyloid in the brain, who are the top line in blue. So there are pre-symptomatic changes. What's difficult is teasing these out on an individual basis. So where are we headed next? So in our clinics, we can do some brief cognitive tests and some summary scores. Ideally, people will have formal neuropsychology. But I think that where we're going to be headed to next is using new technology. So as smartphones and home devices become more and more ubiquitous, so there'll be the chance to track data in real time. So we can both look for people's functioning over time in terms of their patterns of behavior, but it's also possible in these top two panels here to send very quick, repeated cognitive tests that can be done quickly on a smartphone, serially and repeatedly over time, to get a much better view of people's cognitive function, not in a one-off in the clinic, but in a much more real-life setting. And moving on from that, there's the possibility of using all the remote technology that we now have in our houses and will increasingly have, and actually having setups that can monitor multiple aspects of cognition and daily function, but also integrate those with functioning around the house and healthcare behaviours and so forth, to give a much more nuanced picture of people's cognitive health and be able to pick up much more subtle decline. So moving away from these rather crude bins of normal mild cognitive impairment and dementia into much more subtle graded changes. So in summary, I hope I've provided the case that cognitive assessment is at the heart of any diagnosis of cognitive impairment, and the aims are at this stage to distinguish normal aging versus subjective cognitive decline versus mild cognitive decline of various types and functional cognitive disorders, and to distinguish those from a mild dementia. And in due course, we want to help identify preclinical change, which would need to be done on an individual basis. The key aspects are decline from prior function and whether or not people have objective cognitive impairment, and any testing needs to account for age, premorbid function, and ideally to be very quantitative. Screening tests which use in clinic do have utility, some more than others, but formal neuropsychology, where it's available, is invaluable about providing objective quantitative measures. Defining abnormalities, especially as early subtle change, is not straightforward, and indeed cut-offs are useful but are not biological. People don't tip from one category to the next. Increasingly, we're going to use cognitive assessment, which is supplemented by biomarkers, and in the future there'll be moves towards more digital, remote and repeated assessments. So thank you very much indeed for your attention.
So thank you very much for that talk, Jonathan. That was very interesting and very comprehensive. And I'm also very happy that you were able to join us at last, despite some technical issues in the beginning. And I welcome everyone to ask Jonathan any questions you may have with regards to his talk. And I see that there are already a couple of questions. There's one from Haitor who asks, do you apply the neuropsychiatric inventory test in evaluation of MCI patients?
So there are clearly a huge range of different assessment tools that different centres use, and it's appropriate that we want to try and use a tool that's appropriate for the stage of the disease, but also one that the investigators are used to using. So the neuropsychiatric inventory was designed many years ago and has got lots of utility, but really more in established dementia, and particularly some of the more advanced dementia. So the NPI is often testing some domains that really aren't so relevant in MCI. These are hallucinations and agitation and aggression and sleep disturbance and so forth. So I don't think that the NPI is likely to be terribly useful in this setting, though of course is, when the disease becomes more advanced.
And might I just ask a follow-up question on that line, Jonathan? Because I've seen some researchers suggest the idea of a sort of a behavioral variant of mild cognitive impairment, so that instead of having cognitive impairment, some patients who go on to develop a dementia disorder might actually have initial symptoms that are mostly characterized by behavioral changes. What are your thinking on this idea? So sort of a mild behavioral change impairment.
So absolutely. So I think there's a few things to be said about that. I mean, I think as I hope the talk has brought out, whilst MCI was initially sort of really done as to drive to detect early Alzheimer's disease, clearly MCI in its different forms is also going to be a useful concept in detecting other neurodegenerative diseases. So, for example, frontotemporal dementia, when of course you are going to get quite a lot of behavioural change, and of course we know that behavioural change can occur in Alzheimer's disease as well, although is much rarer than the amnestic forms. I guess the issues that we have with detecting mild behavioural changes, first of all, is extremely difficult, and human behaviour is so complex, and the changes that occur with ageing, and it is very difficult to often determine whether something is pathological or it's within the limits of normality. And when there are clear evidence of behavioural change, then we have to work out, is this a manifest manifestation of depression or other non-neurodegenerative features, and that might go within this sort of increasingly interested area of functional cognitive disturbance, or if not, is this really a manifestation of behavioural variant frontotemporal dementia? And so I guess one's trying to look for concrete examples of this, and again, things that really are out of characteristics for that individual, and particularly for perhaps then referring to the criteria for FTD, so the sorts of criteria that we got about loss of empathy or eating behaviours and so forth. But I do think that whilst the subtle behavioural changes certainly are going to occur early, they're often very, very difficult to pick up in the very earliest stages, and it's often much only with time when one can see that these are actually emerging.
Okay, thank you. And I guess also one should use all the clues that are there to diagnose the underlying cause, including subtle changes in behavior or personality, if you can pick them up, basically.
Absolutely.
Then there's a question from Daru, I think it's pronounced. Perhaps it's a bit off topic, perhaps, but are there any interventions for SCD?
So, I think that the concept of SCD is very much changing now, and I would very much refer everybody to the paper in the Lancet Neurology that came out within the last couple of months, which is really, I think, starting to define SCD in more detail. The concept's been around for years now, with more and more the different criteria coming on, but I think it's really reaching a sort of more mature stage now. I think the issue always with SCD is whether these individuals are or are not on the trajectory of Alzheimer's disease. And certainly, I think some of the features that are now being defined in terms of SCD plus and incorporating SCD with biomarkers is really trying to determine whether or not these individuals are on the trajectory of Alzheimer's disease. So for those patients with SCD who we think are on the trajectory of Alzheimer's disease, so first of all is following them over time is going to be important, possibly considering trials, although trials in SCD really aren't really up and running at the moment. But of course, there aren't any specific therapies that we have really in the MCI phase, let alone in the pre-MCI phase, which we're thinking about SCD, if it's due to Alzheimer's disease. For those people who have SCD who we don't think are on the trajectory of Alzheimer's disease, then these individuals clearly have concerns about their cognition. And I guess it's ruling out other potentially treatable manifestations. So those with depression, those with anxiety, those with obstructive sleep apnea, those with other features which could be amenable to treatments that can alter their symptoms and their thoughts about their symptoms as well. Some of these people, it may be psychological interventions like cognitive behavioral therapy as well. That all depends on determining who and who is not actually in the earliest stages of a neurodegenerative process.
And I guess, what about sort of the basic idea of subjective cognitive decline? Is it really just a matter of not having sensitive enough cognitive tests to detect the impairments that these patients are feeling? I mean, if we reject the notion that they have some sort of sixth sense about a premonition about getting ill, I guess it is a real change in their cognitive abilities that they're feeling, but we just do not have the measures to detect this. What is your thinking on this?
I think that's right. But again, I think what's important is that this is a heterogeneous syndrome and it's not a diagnosis. So there will be some people who genuinely have the starts of a neurodegenerative process. And in which case, I think that more subtle tests, repeated tests, computerized tests that aren't just probing standard aspects of memory, but much more detailed testing or testing delayed memory in a more subtle fashion may well pick up objective changes. But there are definitely a group of patients with SCD who are not on the neurodegenerative path. And in fact, it may be as helpful to try and determine those individuals as well. And again, more sensitive cognitive tests to prove that they're within normal limits, which they are on standard tests, and or biomarkers, because I think increasingly we are going to move to Alzheimer's disease as a biomarker construct with the cognitive features as well. And as we move, as well in other talks, I'm sure, throughout these sessions, as we move towards more tangible, easy to develop at scale biomarkers, blood-based biomarkers, I think we'll be able to piece this all together. But yes, in essence, we want ever more sensitive tests either to pick up objective impairment or to prove that it isn't there as well.
Okay, thank you very much. We have to adjourn for a break, 15 minutes break, and then we will return with the next talk. So I'd like to thank you once again, Jonathan, for this excellent talk and Q&A.